Welcome and thank you for coming. I really appreciate it, especially on this awful weather that we've had today. We've had a few last minute cancellations and unfortunately we weren't able to make it available online. So I really appreciate you coming. To the Research Symposium. I'm Victoria Manning. I'm a professor in addiction studies at Monash University and head of research and workforce development here at Turning Point. It's been several years since we've actually come together like this to celebrate the research that we do at Turning Point and Monash. And whilst I'd like to say, well, there was a global pandemic that stopped that happening for 3 years, it was probably about 3 or 4 years before that. So it's really long overdue, and I'm really excited about what we're going to hear today. Before I officially start the day's proceedings, I'd like to acknowledge the traditional owners of the lands that we're on, the Wurundjeri Woiwurrung people of the Kulin Nation, and pay my respect to elders past and present, and extend that respect to any First Nations people with us here today, in person or joining us online. I recognise sovereignty was never ceded, that this always was and always will be Aboriginal land. I'm very fortunate to live right next to the beautiful Merry Creek, and I've learned through a fellow dog walker that I often see there that the Wurundjeri people did not live permanently in settlements on country, but rather they lived in for extended periods where food was plentiful. And they moved on when the land needed to be rejuvenated. And so I was reflecting on this and thinking, well, there's really a message there for us as researchers. It's really important that we remain agile and resourceful and that we respond to opportunities and key priorities. But at the same time, we mustn't neglect the foundations and the important work that we've begun that's often unfinished. I'd also like to acknowledge the expertise, bravery and wisdom of the lived experience workforce and our clients and their contribution in designing and developing services that are accessible, safe and effective. So the intention of today is really to showcase the incredible breadth of research that we do here, to share with you some findings for some recently completed studies, to highlight some of our current work, and importantly, acknowledge and thank the numerous people that we've worked with in producing that work: clinicians, collaborators, partner organisations, funders, and many, many others. It's wonderful to have this opportunity to collectively reflect on the successes and the opportunities for even greater impact on policy and practice. It's wonderful to see so many familiar faces and some new ones too, perhaps existing or even prospective collaborators or funding partners. I thought it might be helpful to begin with a bit of an overview on who we are and what we do. So the work that you'll be hearing about today really comes from the two research teams here at Turning Point, the National Addiction and Mental Health Surveillance Unit, or NAMSU, and that's led by Associate Professor Deb Scott and Dr. Rowan O'Gill, and the Clinical and Social Research team led by Dr. Michael Savage and Associate Professor Shalini Arunagiri. We're a pretty big team. We've undergone enormous growth in recent years. There's now around 60 of us, and we were across all of the different career stages. Around 20 of us have academic appointments at Monash University, and we're truly multidisciplinary. We come from fields that span social sciences, psychology, psychiatry, pharmacology, neuroscience, occupational therapy, epidemiology, and public health. And at any one time, we're conducting around 50 research projects. Last year, we were successfully awarded over $10 million in research funding from government, competitive funding bodies, and philanthropy. And that's enabled us to do a lot of the work that you'll be hearing about today. So as well as the two research teams that we have a comms and policy team and a research support team. And I'm incredibly grateful for all that they have done, especially our research manager, Ellie McSheedy, and Ian Logan for all their work in preparing for today's event. It's a huge privilege to lead this department, which I've done for the last 6 or 7 years. I'm extremely proud of what the research teams achieve, and I want to thank all of our research staff for their hard work and for their continued dedication and contribution to work that truly changes the lives of those affected by addiction. So the overarching objectives of our research programme is really to discover new solutions to addiction and related harms, and to transform policy, practice and community attitudes by addressing real-world issues at a local, state and national level. Our research with the federal government and the Victorian Department of Health and the AOD sector here means that we address research questions that are relevant and important for our stakeholders. And by being part of an organisation that also delivers clinical services and education and training, our research discoveries are both informed by and translated into practice and shared with the workforce through our various training programs, which ultimately strengthen its reach and impact. But essentially, our research is centred around these three key themes. The first is around identifying at-risk populations, examining emerging trends and harms in the community, predominantly through the work of our NAMSU projects, but also understanding the socio-cultural context of addiction in qualitative and ethnographic projects. We identify AOD harms via the National Ambulance and Surveillance System, which is the only one of its kind globally. Each year, our amazing team of researchers and coders in NAMSU code close to 1 million de-identified ambulance electronic patient care records, extracting relevant information on AOD, mental health, suicide, and self-harm. The resulting data on those acute harms can act as an early warning system to new and emerging trends or hotspots, and they can inform population-level policies and interventions, as well as evaluating the impact of those interventions. And examples are declining rates of prescription opioid overdoses following the introduction of the real-time prescription monitoring SafeScript and the rescheduling of codeine, and reductions in heroin overdoses with the opening of the medically supervised injecting room. And this afternoon, you're going to be hearing lots more from the NAMSU team and about the NAS projects and other health surveillance data systems that team manages. Now, we know that only a quarter of those who experience an alcohol and drug problem ever seek treatment, and that there's this, on average, 18-year delay between the onset of problematic use and seeking professional help. So our second theme is around engaging people, understanding and overcoming the barriers to treatment through novel and early interventions to targeted populations, and empowering communities to support people affected by alcohol and other drugs. So this research aims to reduce harms with specific populations, and that includes people at an individual level. For example, our Health for Her project you'll be hearing about this morning, where we developed and trialled a tailored health promotion intervention to women attending breast screening clinics, with the aim of raising awareness of the strong link between even low levels of drinking and breast cancer, and to motivate reductions in harmful drinking. Targeting families, we ran a project funded by the Alcohol and Drug Foundation in partnership with Shark to pilot an online peer-led support group for affected family members, where participants were recruited through the Breakthrough program and showed significant improvements in their self-efficacy and coping skills after attending the family peer support groups. We ran a number of trials exploring the relationship between addiction and sleep, for example, for people with chronic pain, that was funded by the Eastern Health Foundation. And last year, we did a qualitative and quantitative study funded by Vic Health, which aimed to change drinking cultures in the hospitality industry using animated documentaries. And to build safer communities, we're currently running a study funded by Vic Roads, testing a roadside referral intervention at the point of drink or drug driving detection to reduce recidivism and increase motivation for help seeking. And in a project funded by the Transport Accident Commission, we're exploring using qualitative methods and motives and experiences of drug driving to inform future initiatives. So the third and final theme is around really having an impact on client outcomes by developing and trialing novel pharmacological, psychological, neurocognitive, and peer-based interventions. We work closely with Turning Point's clinical workforce, running randomized control trials of new medications. This includes those that you see listed on the left-hand side of the slide: N-acetylcysteine and lisdexamfetamine for people with methamphetamine use disorders, e-cigarettes and nicotine replacement therapy for clients leaving inpatient withdrawal treatment, and depot-buprenorphine for people with opioid dependence. And we're currently, or soon to be starting, a number of trials that you see listed on the right-hand side of the slide. This includes N-acetylcysteine for alcohol use disorder, CBD or cannabidiol for cannabis use disorder, and also we're trialing oxytocin for women undergoing methamphetamine withdrawal. And we have an NHMRC synergy grant, which will enable us to explore new pharmacological and neurocognitive targets for alcohol use disorders, as well as sleep, building on some of the work that Rowan and others have done at Turning Point. In terms of psychological interventions, today you'll be hearing about a large trial that we did of our telephone-delivered Ready to Change program to reduce harmful drinking among people in the community. And we've recently completed a similar study targeting people in the community with the same Ready to Change program, but who want to reduce their methamphetamine use. Well, soon, and we're really excited to soon be starting a trial of MDMA-assisted psychotherapy. And this is for people with comorbid PTSD and alcohol use disorders, building on the successful evaluation of the COPE program that's run for women here at Turning Point that you'll be hearing about soon. And finally, we have a program of neurocognitive intervention trials examining cognitive bias modification, or CBM, with various treatment and community populations who want to reduce their use of alcohol, methamphetamines, or tobacco. And we're extremely grateful to have worked with over 10 other addiction services here in Melbourne to run a lot of those trials. We'll soon be commencing a large community trial of that intervention funded by the NHMRC. And we're also starting to explore using psychophysiology equipment, the mechanisms underlying CBM and craving. That should give us a better sense of how it works. I strongly recommend that you have a chat and grab any of the researchers that you hear talking today, or if there's anything that you hear that piques your interest. And I really hope you enjoy the day. Hopefully that's given you a bit of a sense of what we do here at Turning Point. The focus really for us in the next sort of 3 to 5 years is to increase our student cohort, specifically PhD students, and we're hoping to secure more externally funded scholarships to support the career development of our future addiction researchers. We wish to continue building the capacity of our early career researchers, including via our Emerging Leader program. We also want to really ramp up our research impact, in particular the translation of effective interventions into practice by leveraging our clinical networks and expanding the use of ambulance and other surveillance data. I just thought I'd mention 2 projects that are quite ambitious in nature that we're sort of in the planning stages of and hoping to secure some funds to do. One in the NAMSU team is really leveraging the impact of the NAS data through data linkage and also by mapping the use of services over the community harms. The other in the clinical and social research area is really where we will examine what's strengthening recovery pathways beyond treatment. We're doing lots in the sort of treatment innovation space, but we're really wanting to have a better understanding of what it is that enables people to keep moving forward with their recovery journeys. So we're hoping to be able to secure some funding for what would be Australia's largest cohort of recovery pathways, examining the impact of different types of peer support on those recovery trajectories. So they're just a couple of projects that we're planning, just to as a little teaser there. I think at this point, I know we've plenty of time, but I think it's probably good time to hand over to Shalini, I think, who will start the first session on interventions.
Brilliant. Thanks everyone who's made it in on time today. I know it probably wasn't easy today to get through the traffic. So we're going to kick off this morning with some rapid fire really presentations to tell you a little bit about the story behind some of the studies you've already heard about. As we mentioned, we work across a number of themes here at Turning Point, and our research tends to be fairly interdisciplinary from that perspective. But we're going to start off this morning focusing on intervention specifically. And the intervention span that sort of engage and impacts focus. I have the pleasure of opening that session, and I co-chair our CSR team with Michael Savage, and we run a whole range of different intervention research within that stream. I'm also a clinical director of the Hamilton Centre, where we're conducting a range of projects that look at co-occurring disorders within the mental health and addiction space. So it's my pleasure to be able to open the session. Some housekeeping rules as we start off this morning. There'll be some presentations, there'll be 6 of them back to back. We're doing 8 minutes for each talk. So you'll hear a little bit about the story behind some of these interventions. Hopefully there'll be an opportunity for you to be able to talk to the researchers in the break, but we're not going to do any Q&A. So try and keep those questions in your mind until the break. We're also not going to do any bios. So all our bios are on our webpage. So it's encouraging you to go on our website. But hopefully you'll have an opportunity to speak to people during the break as well. We're starting a little competition. So if you don't mind kind of scanning that QR code, we're actually getting audience votes and the best presentation within each section. So there are 3 sessions until you get to vote 3 times. You've got the code here. If you forget or you can't manage that, at the end of the session, we'll put the QR code up again. But keep that in mind as you hear the 6 presentations coming up. So we'll start off. So it's my pleasure to welcome up our first presenter of the day, Dr. Jasmine Grigg, who'll be talking to you about alcohol consumption among women from the Health for Her project.
Good morning, everybody. So for some background, there's strong evidence that alcohol is a major modifiable risk factor for female breast cancer, even in very low amounts, and with one average restaurant serve of wine a day, increasing breast cancer risk by as much as 23%. Globally, 4.4% of breast cancer cases and 10% of breast cancer deaths are attributable to alcohol consumption, with these proportions even higher in Australia, of at least 6.6% of cases and 18% of breast cancer deaths. And among women who've been treated for breast cancer, drinking low amounts of alcohol can increase the risk of recurrence. Yet while there's 50 years of research demonstrating the alcohol breast cancer link, population awareness of this risk has remained surprisingly low. And while Australia's use of alcohol is declining, the prevalence of risky drinking has increased among mid to older aged women, likely due to social, cultural, and economic changes, including women's participation in the workforce and education and greater financial independence, but also due to prolific and deceptive marketing by alcohol industry, including the exploitation of breast cancer awareness campaigning to sell more products and ultimately contribute to risk in the name of prevention. For example, the sales of this pink glitter edition Chardonnay help fund breast cancer clinical trials. A wine distributor has partnered with a pop icon, breast cancer survivor, and awareness campaigner on a range of wines, selling 800 million bottles since 2020. And winemakers are raising funds for an Australian breast cancer support and education charity. But although alcohol consumption among mid to older aged women continues to increase, this issue remains largely overlooked, and health information about the alcohol breast cancer link isn't systematically provided. For example, in one recent study looking at the experiences of women attending breast cancer screening and treatment settings in the UK, women commonly reported that not once did the subject of alcohol come up. So given all of this, we started to wonder whether we had a case for implementing a brief alcohol intervention within our national breast screening program. As a first step, we analysed the alcohol consumption data of more than 49,000 breast screening service consumers. As a reminder, the current national guidelines established by the Australian National Health and Medical Research Council to reduce alcohol-related health risks recommend healthy adults drink no more than 10 standard drinks a week and no more than 4 standard drinks on any one day. Of women in our study, results show the majority had recently consumed alcohol. 1 in 5 were drinking at a level exceeding national guidelines for weekly consumption, and 1 in 6 were exceeding guidelines for consumption on a single day more than once a month. Sorry. So, okay. So while women attending breast screening might typically be considered a more health conscious group, this study found risky drinking to be highly prevalent among this large sample. These findings indicate a need to address risky drinking among this population and are concerning in light of strong evidence that drinking even low amounts increases breast cancer risk. Indeed, Canadian guidelines revised in January of this year mark a substantial shift in operationalising risky drinking, recommending consumption of no more than 2 standard drinks a week to lower risk of alcohol-related harm, which is just 2.5 standard drinks per week using Australian measurements. In the same month, the World Health Organization published a statement in the Lancet Public Health declaring that no safe level of alcohol consumption can be established, with the causal link to breast cancer mentioned multiple times. So after establishing the prevalence of risky drinking among women attending breast screening services, we worked with women to collaboratively design a brief alcohol intervention to be tested in the breast screening setting. Women offered several ideas for the design of the intervention, which we called Health for Her, such as providing alcohol information alongside general lifestyle information to make the intervention relevant to all women, and so that women who drink didn't feel singled out. We then conducted an implementation effectiveness trial of the Health for Her intervention with 558 women at Maroondah Breast Screen, funded by Vic Health and the Eastern Health Foundation. We found Health for Her to be effective in improving women's knowledge of alcohol as a breast cancer risk factor and in improving alcohol literacy more broadly. For example, Laurel said, and it's quite small, "You don't think breast cancer is something that happens because you might drink a bit too much." And meanwhile, Cordelia said, "Hearing about the actual serving sizes made me much more aware of how much I was drinking." While the study was empowered to find an effect in reducing women's alcohol consumption, some participants reported that they reduced their drinking as a direct result of the intervention. Helena said, "I moved from 3 alcohol-free days to 5 consecutive alcohol-free days, and I felt good about that." Meanwhile, Lauren said, "You know, maybe on a weekend, if I'd had 5 scotches, I now might have 3. Of women who received Health for Her, 99% reported that the information they received was acceptable. 97% reported the information to be trustworthy. As Vicky said, the affiliation with Breastscreen, the information was coming from a reputable source. And 96% endorsed that it should be part of the standard service provided. Breast screening staff were also highly supportive of Health for Her as part of routine care, and were excited about playing a role in breast cancer prevention. However, for wider uptake and impact, they endorse the need for an automated, self-completed version that requires minimal staff facilitation and disruption to workflow. So building on these findings that we've accrued so far, we're well underway with the next phase of this project, supported by philanthropy group Shades of Pink. We've been working with Action Lab, a group of impact-focused researchers, designers, and IT engineers at Monash University, to develop an automated version of Health for Her so that it can be self-completed by women while at their screening appointment to increase its potential for wide-scale implementation. And we're working with breast screening service consumers to ensure that it's straightforward and easy for women to engage with. We've also taken the opportunity to refine the intervention's messaging on alcohol and breast cancer risk in line with the latest research, and we've refined the alcohol harm reduction content based on feedback from women, including the addition of a few brief interactive activities, an example of which you can see in the bottom right frame, to reinforce the messaging and promote behaviour change. And we're about to test this new version of Health for Her in a single site trial, once again at Maroondah Breast Screen. The results of this trial will allow us to understand if any adaptations are needed before the intervention is tested in a large multi-site trial with a focus on examining change in women's alcohol consumption. We're also aiming to improve accessibility of Health for Her for women from culturally and linguistically diverse backgrounds, and to understand barriers and facilitators of implementation at other breast screening sites, with the goal of implementing Health for Her across Victoria and even nationally. So, to sum up, from the work we've achieved so far, we've identified a high prevalence of risky drinking among women attending breast screening services, and we provide preliminary evidence for the effectiveness of the Health for Her intervention implemented in this novel setting. And we're now working hard to scale up this research for impact. Thank you. And finally, I'd like to acknowledge the great team that's behind this project, as well as our funding partners and collaborators. Thanks.
Thanks so much, Chaz, for that fantastic presentation. It's a great start to the day, and really great that we can also have a shout out to the sponsors of that incredible project that's really occurred over a number of years now. So it's really great to see how it's gone from an initial little pilot and grown over the years to what it is today. My pleasure to welcome our next speaker up, Peter Stragolinos, who's going to talk to us a little bit about Ready to Change intervention you heard about before, and telling you about alcohol in relation to that.
Thank you. So alcohol consumption is a leading cause of preventable morbidity and mortality globally, resulting in around 3 million deaths each year. And alcohol is also one of the most prevalent substance use of dependence. However, treatment rates globally are low, and there have been no increases in treatment rates in over a decade. The majority of Australian the majority of Australians drink alcohol. And while many who drink don't experience harms, recent population surveys have found that 1 in 10 meet the criteria for alcohol dependence. However, just 27% will make treatment contact in their lifetime. And as Vic mentioned at the beginning, there's a median delay in seeking treatment in Australia for about 18 years after the onset of symptoms. So these low rates of treatment seeking and the delays as well is concerning. So exploring alternative treatment approaches is one thing that we can do to try and address this gap. Telephone delivered treatments have potential to overcome individual and structural barriers to accessing treatment, such as a reduction in perceived stigma by allowing people to access services discreetly, as well as increasing service availability by offering treatment in areas with low or no treatment coverage. However, to date, they've been underused and understudied in substance using populations, other than for quit lines for smoking cessation. And while there have been a few studies that have looked at telehealth interventions and they have had some promising findings, there's been no rigorous randomized controlled trials yet. And that's despite the expansion of telehealth services since COVID, including for substance using populations, which presents the urgent need to determine the effectiveness of telehealth interventions to ensure that they're receiving evidence-based care. Which brings us to the Ready to Change alcohol trial. So this is the first randomized controlled trial to examine the benefits of a standalone telephone delivered intervention. The aim of the trial was to examine the effectiveness of the Ready to Change program in reducing alcohol problem severity among a general population sample with problem alcohol use. We recruited 344 participants from all across Australia, and all assessments for this trial were conducted over the phone. The study also included a qualitative component with semi-structured interviews conducted with 35 participants who received the Ready to Change program. So the two intervention groups are listed here. So the intervention group received the Ready to Change program, which is 4 to 6 sessions of a structured telephone intervention delivered by a psychologist. The program uses evidence-based behavioural interventions such as cognitive behavioural therapy and motivational interviewing. While the active control group, they received 4 5-minute check-ins with a researcher, as well as some pamphlets on the Australian alcohol guidelines and stress management. So the participants in this trial were around 40 years of age, and just over half of them were male. Around 2/3 were living in a major city. However, when we explored the rate of participation by geographic area and population size, participation was actually higher in non-metropolitan areas. We also found that the majority of participants were first-time help seekers, despite reporting high alcohol problem severity. So at baseline, more than 60% were scoring in the probable dependence range on the audit, which is the alcohol use disorder identification test. And when we were looking at the alcohol consumption at baseline, participants were drinking around 20 days per month, and most of those were heavy drinking days. And so on average, participants were consuming around 170 standard drinks over the past month, which is more than 4 times than what's recommended by the Australian guidelines. And so for the primary outcome, we found significant decrease in the audit total score from baseline to 3 months in both intervention and control groups. However, we didn't find any significant change between these groups. Where we did find a point of difference, we found that the Ready to Change group showed greater reduction in hazardous use relative to control. And then when we looked at those who had done at least 2 of the 6 sessions, we found positive results in the Ready to Change group on nearly all of our secondary alcohol outcomes, indicating that people were more likely to see benefits from this program if they had attended at least 2 of these sessions. And I also wanted to share some of the findings that we had from the qualitative study. The telephone mode of delivery was perceived to be a key advantage and an essential part that facilitated participation in this treatment. For example, David said, public transport out here in the country is absolutely ridiculous. So I don't think it would have been worth the time to go and see a counsellor. And Sally explained, I think it's easier for people, especially like me, who work full time. It wasn't taking my time or my ability away from the things that I have to do. So these quotes here kind of indicate that it was really easy to do, it was low burden, and they could kind of fit it in with their day. Another theme that emerged is that participants reported a relative sense of anonymity and described reduced feelings of stigma due to the treatment being delivered over the phone. And people would disclose that they wouldn't have been able to share these things if they'd been sitting opposite someone. As Lisa described, I felt very relaxed so I could be open and honest, and I didn't have to avoid someone's gaze. It just felt a little bit easier. So the results of this study highlight the potential benefits of this highly scalable model of alcohol treatment and the potential to reduce a treatment gap for problem alcohol use, particularly among those who haven't previously sought treatment. And as Vic also mentioned, we are in the process of completing another randomized controlled trial of the Ready to Change program, but this time for people experiencing problems with methamphetamine use. So Australia has one of the highest rates of methamphetamine use in the world, and cognitive and behavioural interventions have been found to be the most effective in reducing substance use among this population. So testing the efficacy of the Ready to Change program with this population would just help us to further understand how useful it is and what type of effects this has having treatment over the phone. And it's been a large group of people who have been working on these projects. So just wanted to quickly thank the team as well. So thank you.
Thanks, Peter, for a really quick overview of a whole bunch of work, a lot of publications and a lot of years of recruiting participants and well through our methamphetamine trial as well. So thank you for that. Moving on to a couple more presentations now, covering off that stream of research that Vic Manning leads here around neurocognitive interventions. And so really happy to welcome up to the podium Shua Garfield, who's going to talk to you about approach bias modification.
Okay, so cognitive psychology research suggests that repeatedly experiencing the rewarding effects of an addictive substance or using an addictive substance can cause what are called cognitive biases, which includes changes in thought, emotional, and behavioral processes. And these can include, is this a laser? On the touchpad. Okay, so that's not, all right, never mind. So these include attention bias, which is an exaggerated tendency for your attention to be, to be drawn to stimuli associated with the drug. There's interpretation bias, which where your thoughts are sort of biased towards positive rather than negative evaluations of the drug. Memory bias, which involves an exaggerated tendency for memories of the drug and its effects to occupy your mind. And approach bias, which involves an exaggerated, which involves impulses to approach the drug or stimuli associated with it. So since these biases are believed to contribute to the development and maintenance of addiction, researchers have developed cognitive bias modification training programs that aim to reduce these biases in the hope that that could help people who are trying to quit or reduce their use. And so far, the most promising type of cognitive bias modification in terms of helping prevent relapse has been approach bias modification, which I'll refer to as ABM for the rest of the talk. So ABM is a simple behavioral training task, usually delivered using a laptop and joystick. Participants are instructed to respond to images by pushing or pulling the joystick. Usually the instructions are based on something like how the frame around the image is oriented. So for example, in our ABM task, we instruct people to push the joystick away from themselves if the frame, as in this image, is in a portrait orientation. And pushing the joystick shrinks the image, so it simulates that if you're pushing the image away or avoiding it. And then if you have an image in a sort of landscape oriented frame like there, that you're meant to pull the joystick towards yourself, and that sort of simulates approaching the image. And we program the task so that 95% of the images in the portrait frames depict alcohol beverages and 95% of the images in the landscape frames are non-alcoholic, so that people doing this task are repeatedly pushing away alcohol and pulling some non-alcohol alternative towards themselves. And this is meant to reduce that alcohol approach bias by practicing avoiding alcohol images until that response becomes automatic. And we recently ran the world's first large multi-site randomized trial of delivering ABM during inpatient alcohol withdrawal treatment, which is often known as detoxification. The aim was to see if doing ABM during that sort of 1 or 2 week detoxification treatment could help people remain abstinent from alcohol after they left treatment. Because we know that the majority of people resume drinking within a few weeks of leaving detoxification, and that's likely to stop many people from engaging in ongoing treatments such as counseling or rehabilitation. So we thought that if we could even just help prevent relapse for just a short time, that could have ongoing benefits. So we recruited 300 participants. The sample was majority male, average age in their 40s, which is typical of the alcohol withdrawal treatment population. 3/4 of them were unemployed, 3/4 had psychiatric comorbidities, 2/3 had previous episodes of withdrawal treatment, and their average alcohol consumption was almost 600 standard drinks per month. So this is quite typical of the quite severe chronic health and substance use and social problems often seen among detoxification patient populations, which can prevent major obstacles to positive treatment outcomes. So we asked participants just to complete one single 15-minute training session each day for 4 days in a row, so 4 sessions in total. And in each session, they responded to 240 images, 120 alcohol, 120 non-alcohol. And half of the participants were randomly assigned to receive ABM, and the other half received a control version of the training. So as I mentioned before, participants in the ABM group were trained to push away 95% of the alcohol images and approach 95% of the non-alcohol images. And in the control version, they were just meant to push 50% of alcohol and 50% of non-alcohol just to the left or right. So they got the same exposure to the images and sort of the feeling they were doing an attentional training task, but it wasn't actually designed to change that approach bias. So 2 weeks after they left withdrawal treatment, we phoned them to assess their alcohol use. Less than half of the people in the control group had remained abstinent from alcohol for that time, but that rate of abstinence has actually increased by 12% in those who got ABM. And that is the effect, that sort of 12% increase is the effect that we got when we included all 300 people who started the training, even if they didn't do all of their 4 training sessions. If we analyzed only those people the 240 people who got the full 4 sessions of training, the effect size is even larger, with ABM increasing their abstinence rates by 17% and almost 2/3 of the ABM group remaining abstinent for at least 2 weeks, compared to less than half in the control group. So we followed participants up several more times over the following year to find out if they had consumed alcohol. And if they had, we asked them when was the first time they had drunk alcohol since leaving detoxification. And this allowed us to chart the estimated proportion of participants who were still completely abstinent. We found that it only took 12 days for half of the people in the control group to have resumed drinking. But in the ABM group, half of the participants remained completely abstinent for at least 53 days. However, that difference between groups, you see there was a big difference between groups in the first few weeks and months, but then it got sort of smaller over time. So once you're up to about 4 months after they left detox, it's no longer significant, which suggests, not surprisingly, the effects of getting just 4 sessions of ABM just during that detoxification weren't permanent. However, reducing relapse rates, even for a few months in this difficult to treat population, was pretty encouraging. And so the findings of this trial have led to several clinical and research outcomes. So the Australian government's alcohol treatment guidelines mentioned ABM for the first time in their 2021 edition. One residential rehabilitation program has adopted our ABM program as part of their standard treatment for alcohol patients. And several other withdrawal and rehabilitation services have expressed interest in using it. So, and we're hoping to obtain funding for research on how it can best be implemented as part of routine care in these settings. We've also followed up this project with several further programs of research. So this includes the world's first trial of ABM for methamphetamine use disorder. It also includes testing ABM smartphone apps, which Hugh Piercy will describe in the next presentation. And we're about to commence laboratory-based psychophysiological research to test how different cognitive biases, craving, and emotional responses relate to each other, which we hope will better clarify the mechanisms of how ABM works. And so in addition to the people I listed in the first slide who were co-authors of this presentation, there's also a whole bunch of other people who I should also acknowledge who participated in the study, helped design it, facilitated recruitment at the 4 services we collaborated with, which are listed there, who helped with collecting and analyzing data and helped prepare this presentation too. And so that's all.
Thank you so much, Shura. And I think you've already flagged the topic of our next presenter. So before I move on to Hugh, might just flag that we've got a hashtag for today. So if anyone is on X and is Xing, please feel free to do that with that hashtag and also tag us at Turning Point and be across our social media. So without further ado, I'll move on to the next presentation, and Hugh's going to come up and talk to us about swag.
Alrighty. Yeah, so as mentioned by Shura in his excellent presentation, let's just get to the first slide. Approach bias modification is a type of cognitive training intervention. It's typically completed in person with a laptop and a joystick. And it's been shown to reduce rates of alcohol relapse by around 8 to 13%. About 1 year after residential rehabilitation treatment, with our own research showing that it can reduce rates of early relapse by up to 17% after inpatient withdrawal treatment or detox. Unfortunately, despite the evidence of its effectiveness at preventing alcohol relapse, it can be quite difficult for individuals to access ABM outside of a research context. And along with this, we know that a lot of individuals with an alcohol use disorder typically either do not or cannot access treatment, which further limits access to this rather promising intervention. So to address all of these limitations, I think that's working. Yep. We developed the Swipe app, which is a personalized and gamified smartphone app that can deliver approach bias modification to anyone that owns a smartphone. Because it's personalized, users can upload images of the specific alcoholic drinks that they want to avoid, and then they upload images that represent healthy alternatives or personally meaningful goals that they want to do more of, such as pictures of family, exercise, a wallet, etc. So in 2020 and 2021, we ran the Swipe pilot trial, where we aimed to test the feasibility, acceptability, and preliminary effectiveness of smartphone-delivered approach bias modification, which was the world first at the time. We recruited 1,309 participants from across Australia who were drinking at hazardous or harmful levels, and they were instructed to download the app and complete 2 sessions of ABM per week for 4 weeks. And then they completed some follow-up questionnaires at the end of the 4-week intervention period, as well as a 1-month follow-up as well. So we successfully recruited our original target sample size of 500 participants within the first 26 days, with users also completing about 98% of the sessions that they commenced, which really supported the overall feasibility of this smartphone-delivered approach bias modification intervention. Participants also rated the app as being highly acceptable on the mobile application rating scale, which is a standardized measure of app acceptability. And a lot of our app user feedback as well supported the app's acceptability among the users. With regards to the app's preliminary effectiveness, we had a number of really positive findings where we found that participants significantly reduced their past week standard drinks by 8.4 and their past month drinking days by 4.7. And we also observed some significant reductions in participant scores on a measure of craving frequency. And there were also significant reductions in participants' severity of alcohol dependence as well, where at baseline about 98% of the sample scored in the likely dependent range on this scale, and it's reduced by around 11% at the end of the 4-week intervention period. So we also found that participants in the moment craving ratings, which they did sort of before and after each session on the app, these significantly reduced after each session, as you can see on the bottom, it's just sessions 1 to 8 on the chart there, which really suggested that the app might have this, might be an effective tool for craving relief. So people could just pull out their phone when they have a craving, do a 3-minute session of approach bias modification, and hopefully see a reduction in their strength of their craving. And finally, when we looked at the proportion of participants who are drinking within national alcohol consumption guidelines, so those recommend having no more than 4 standard drinks in a single day and no more than 10 standard drinks in a week. At baseline, only 5.4% of participants were drinking within these guidelines, and this increased to 23.6% at the end of the 4-week intervention period. So as part of this project, we also conducted some qualitative interviews as a sort of sub-study with 18 of our participants in order to really try and get a deeper understanding of their experiences using the app. So without going into too much detail, I did just want to show you some of the feedback from the participants, which really highlights the way that the app helped them. So one of the themes that emerged from these interviews was this idea that the app could act as a sort of a circuit breaker, where participants reported using it to interrupt this sort of alcohol autopilot mode of just habitually drinking, and they might instead go for a walk or a run or do something else. And this really aligns with the findings from the previous slide showing this, this immediate reduction in craving after completing a session of approach bias modification on the app. I also really like this quote just in the bottom right here as well, which illustrates how the personalized image selection helped some of the participants remind themselves to avoid alcohol. This person said, "I thought about going past the bottle shop and grabbing a 6-pack. In Swipe, I used a photo of my wallet to remind me, no, just go home and have an alcohol-free night," and it worked. So after the success of the Swipe trial, we're now running a number of randomized controlled trials on smartphone delivered approach bias modification in order to more rigorously test how it compares against a control condition in an RCT and to see whether it can be beneficial for different treatment populations as well. I should also just note that the name was changed to ATAP instead of Swipe in order to reduce the likelihood of unblinding our participants, but the actual approach bias modification component is virtually identical. So we're testing this with individuals accessing outpatient treatment. We're also looking at whether it can help prevent relapse among individuals who are leaving residential rehabilitation treatment. And we're also investigating whether the app can be beneficial for older aged adults in the community who are drinking at hazardous levels. We also have 2 upcoming trials of our latest version of the app called Modify, which has a number of improvements to its design and some structural changes as well that allow us to follow up participants for much longer time periods than we've done in the previous trials. So the first Modify trial is quite an ambitious project where we're aiming to recruit 1,600 participants from across Australia that are drinking at hazardous or harmful levels, where we'll follow them up over the course of a year to determine the app's effectiveness at reducing alcohol use and cravings, as well as a number of other different measures. And we'll also be conducting some health economic analyses as well to determine the cost effectiveness of delivering smartphone ABM. And our second trial, the Modify Tobacco study, is a version of the app that's been adapted for smoking. So we'll be recruiting 200 smokers in Victoria, and they'll be able to select images depicting cigarettes, as well as healthy alternatives and goals that align with their reasons for quitting smoking. And then they'll use the app over the course of the 4-week intervention period. So in 2022, we translated our research findings from the Swipe pilot study and made Swipe available to the general public, where we received over 1,400 downloads. It was also picked up in a few different media places as well. And our approach bias modification research at Turning Point has also helped result in ABM being included in the new Australian alcohol treatment guidelines that were published in 2021. So one of the really exciting things I think about approach bias modification is that because it achieves its effects by training users to avoid images depicting undesired behaviors, it can be quite easily adapted to a broad range of different addictions and negative health behaviors. So currently our research has been pretty solely focused on alcohol use in an Australian context. But when we start to expand these numbers internationally and consider other behaviors such as smoking, gambling, unhealthy eating, and substance use, the broader potential impacts of research in this field are quite staggering. Brilliant. So thanks so much for listening. I'd just like to acknowledge the hard work of everyone who's been involved across all these different trials. And yeah, thanks.
Thanks, Hugh. That's a really great flyover of a bunch of different presentations around a range of work that's happened probably about, what, Vic, is it 5-6 years? A tremendous amount of work that's happened over a long period of time and really has scaled up, I think, now with the mobile app and new options coming available as well. So watch out for a whole range of clinical trials coming out to you soon. We've got a couple more presentations in this team. We're running ahead of time because everyone's kept bang on time. So having said that there were no questions allowed, we might allow questions at the end of these this session. So start thinking about questions you might want to direct our presenters to. So our next presenter is Dr. Ali Cheatham, who's going to come up and tell you about the EPIC MATOD study that's looking at pharmacists and opioid prescribing.
Hi, everyone. Sorry. There we go. Yeah, so the EPIC MATOD implementation study, just as some background, it forms part of a larger project that we initiated back in 2019 with the aim of improving access to medically assisted treatment for opioid use disorder within the Frankston-Mornington Peninsula region. As you can see in this image, mapping conducted at the time showed that the region had virtually no prescribers. Most patients were being managed by 1 to 2 prescribers in the Frankston CBD, meaning that people further down the peninsula in suburbs such as Hastings and Rosebud West were sometimes travelling up to 2 hours on public transport in order to meet their appointments. We know this can impact retention. It isn't unique to the Frankston region either. It's an issue in many other regions of Australia. So as there was good coverage of MATOD pharmacies across the catchment, we were keen to explore how pharmacists could be used at their full scope of practice to improve access to treatment. And there has been international research in the last few years that's demonstrated how pharmacists' roles have been extended beyond dosing, although a collaborative model where pharmacists work alongside prescribers has not been explored in Australia yet. So just to clarify, this isn't actually about pharmacist prescribing. We have had a little bit of talk about that in the media recently, I know, but it's a collaborative model where they work alongside the prescribers. So yeah, look, I won't go into too much detail about how we developed the model, but we began by forming partnerships with key pharmacy prescriber and consumer organisations, followed by a settings assessment that included interviews or in-depth interviews with local providers and patients. The key features of the final co-design model are at the bottom of this slide and include training and competency assessments for pharmacists, individualised treatment agreements that include optional tasks that can be delegated, as well as regular patient reviews by the pharmacist at a frequency that's determined by the prescriber. And we also developed detailed clinical practice guidelines as well to support pharmacists. So in 2021, we received an ADRA grant to conduct an implementation effectiveness study of the model of care. Clinical outcomes are being assessed among 60 patients who are receiving collaborative care over a 6-month period and being compared with a matched comparison group receiving treatment as usual through the same providers. To understand factors relevant to implementation, we're also doing in-depth interviews to understand with collaborative care patients, pharmacists and prescribers with outcomes mapped to the RE-AIM framework. And we're also doing a health economics assessment just to determine the cost per patient of delivering care using the model. So outcome data won't be available until early next year. But yeah, what I'm going to talk about now is just our progress and then some early findings that provide insight into the potential benefits and challenges in implementing a collaborative model of care for MATOD. So where we're at with recruitment, we have 22 pharmacists recruited, with 15 of those providing collaborative care. This is well above our original estimates of 6 to 10 pharmacists that we thought we'd need for the study, but turned out to be necessary to try and meet our consumer recruitment targets. Since we started the study, the number of prescribers in the Frankston region has actually declined even further. So in 2022, we broadened the reach of the project further to encompass Melbourne's southeast, and we now have 4 prescribers across 3 clinics. This then led to the recruitment of additional pharmacies outside the Frankston region, so we've got a much broader geographical spread of pharmacies than we originally expected. And things are moving very fast at the moment, so our patient recruitment numbers aren't up to date. I think we're at 80 with around 40 in the collaborative care arm at the moment. So in terms of early learnings from this, we've now completed almost 40 in-depth interviews with participants, mostly with the collaborative care participants, but also with pharmacists and prescribers. And the results from these have suggested that the model's feasible and has been received well by all three groups. In particular for patients, the main benefit has been not having to travel to see their prescriber as frequently, particularly for people in more regional areas. I know there's a quote here that talks about 40 to 45 minutes away, but we've had some participants report travelling over 60 kilometres and spending up to 3 hours on public transport in order to get to their prescriber. So the convenience and flexibility of being able to see their pharmacist instead has really been highly valued. Prescribers have also appreciated a reduction in their workload and have also found receiving regular updates on their patients through the pharmacist reviews to be particularly useful. The regular pharmacist reviews have also allowed patients greater time to discuss their treatment. And as illustrated in these quotes, for some participants, the model has actually helped them achieve quite specific goals, including reducing and tapering off methadone. And pharmacist advice and support played a really essential role in this for these people, with the review process being described by the pharmacist as providing a window into the patient's goals that they might not have been aware of otherwise. In terms of adoption, there's been a really high level of enthusiasm for the project among pharmacists, but there's been challenges for some in balancing that with the demands of their regular workload. Obviously, pharmacist capacity was very limited during the pandemic. There were then ongoing staff shortages, although recruitment's picked up considerably in the last 6 months. Even then, though, pharmacists have tended to take on fewer patients than we thought they would, with none providing collaborative care to more than 4 at the moment, regardless of the size of the program. So finally, a really key theme that's emerged regarding implementation is that pharmacists need time to gain experience and to build confidence, regardless of their prior experience with the MATOD program. And as highlighted in these quotes, the pharmacists have been really conscious of the risks involved in making clinical decisions. And although we sort of expect confidence is going to increase over time, the interviews have really highlighted the importance of providing training and ongoing support to pharmacists. Having more than one pharmacist per pharmacy is something that's really necessary to ensure continuity of care, as we found out when one of our pharmacists left and we had to very quickly recruit the other one to take part. But we're also finding out that it might make it easier for pharmacists to take on more patients initially as well. And yeah, remuneration for pharmacists is also something that is really important in making sure that the model can be maintained, because they don't often get remunerated for a lot of the additional things they do. So that's part of the study. We are paying them for the clinical reviews, but on a longer term basis, there would need to be some sort of mechanism for that to be maintained. So in terms of the next steps, we're looking to finish recruitment at the end of September. Although we're unlikely to meet our patient recruitment targets by then, because this is an implementation study, and also considering we've got a much larger and more diverse sample of pharmacies than we expected, we feel like there might be more benefit in having the results available early, particularly considering that there's so much focus on pharmacotherapy reform in Victoria at the moment. We're also beginning to consider the next phase of the project, which involves exploring the potential for scale-up. As I mentioned, that need to expand treatment capacity isn't something that's unique to the Frankston Mornington Peninsula region, although by extending recruitment beyond that region, we have been able to demonstrate that the model is of value to providers and patients in other areas where they don't necessarily have the same geographical barriers, but other barriers to accessing treatment. There's a number of potential applications for the model that could be explored in the future, which would include use in non-community settings, its value in addressing barriers in regional areas. And we've also been considering a streamlined model that reduces the time burden on pharmacists while still retaining the components that seem to provide the most value, which at the moment seems to be enabling them to adjust people's doses, and also the quality of care provided through regular reviews. Pharmacists can also be delegated reinduction, where they can reinduct people back on the program if they miss a certain number of days. I think that's been delegated to every single pharmacist so far, and I don't think it's happened once. So that's a huge part of the training for the pharmacists. So removing sort of aspects like that don't seem to be used as much, we think would really streamline the model. And yeah, we're hoping to have some time in the latter stages of the project just to focus on some translational work to support moving the model into a real world setting. This is likely to involve developing materials and setting up structures and mechanisms to support pharmacists that are able to be sustained outside of the context of a research study. So yeah, I just want to say thank you to all the patients and pharmacists and prescribers who've taken part in the project, to the project team, and also to all of our project partners who've been immensely helpful in developing the model of care and the current study, and obviously to the funders as well for providing the funding for the project. So thank you.
Brilliant. Thanks, Ali. And that was a really great overview of opioid pharmacotherapy. So something completely different in terms of what we've been talking about, but something really relevant, I think, to the sector at the moment, particularly in Victoria and probably nationally. So this is the last presentation of this session, and I'll be doing it. And I think in terms of this session, what you've heard of, I suppose, gives you a little bit of a snapshot of the types of work we do across our research streams at Turning Point. We've got the capacity, I suppose, to look at anything from sort of a screening and health promotion intervention to telephone-based brief interventions, to looking at more in-depth sort of research into models of care, implementation, and effectiveness studies. And I'll tell you a little bit about a program that we're doing with essentially very little to no funding, because we've got the capacity, I suppose, with frontline clinical services to test some ideas out and think about whether or not when we pilot things within a clinical setting and a routine setting, how we can test whether that works and what we can then take away in terms of scaling that up. So just a reminder again of our social media tags. And at the end of this presentation, we'll be taking votes for the best presentation, and we'll also be taking questions for all the presenters this morning. So I'll tell you a little bit about our COPE program at Turning Point. As you've already heard, we work across a whole range of different types of substance use, but we also work with people who have complex clinical problems across a whole range of different kind of spaces, and that includes the construct of trauma or PTSD. So our clinic here, which is actually based here at Richmond, and anyone who's doing the tour with us later will kind of take you around and show you the clinical settings in which many of these programs actually occur. This specific program is funded by Northwestern Primary Health Network, who's been really helpful in kind of allowing us to both conduct a clinical program and also study it in terms of that implementation in a routine setting. Just acknowledging again that this work was conducted in the lands of Wurundjeri people. And so in terms of the prevalence of a sort of PTSD in Australia, just to give you a bit of a snapshot, people are probably familiar with the fact that trauma is very common in people who develop substance use issues. But what we are less familiar with, I suppose, is that PTSD generally doesn't remit without treatment. For most of the people that we see who have severe kind of dysfunction as a result of trauma symptoms, that includes things like nightmares or flashbacks or hypervigilance, difficulty sleeping, difficulty kind of making relationships with other people as a result of their trauma. The challenge is that if we don't actually think about how we support that, how we support recovery from that, people can actually be very stuck as using substances as a way to cope. And there's a whole range of reasons why PTSD and substance use might co-occur. There's reasons in terms of gene and environment interactions. There are reasons in terms of early childhood kind of factors. There are a range of common factors that predispose to both problems. And as we commonly see in substance use services, self-medication, once someone already has trauma symptoms, substance use can be an incredibly effective way to kind of manage those symptoms. But what we know within the clinical setting is once both disorders are present, each of those disorders maintains and exacerbates each other. So for instance, if the trauma symptoms kind of are still there when someone's actually recovering from substance use, it's a big trigger for relapse in that context. So for us, working in this space for a period of time, particularly targeting interventions at sort of emotion regulation, thinking about symptom distress, we got to a point with a lot of our clinical populations that people were kind of actually stabilizing a lot of their substance use, but really keen and ready to kind of work on what they felt was the clear kind of factor that was underpinning their problems in the first place, often PTSD or trauma. So for us, we had to look around and we couldn't find actually any other services to refer people on to. It's a real challenge for clinical populations who can't actually find trauma-focused treatments that both treat substance use and trauma at the same time. There's a paucity of those types of treatments within the public sector, but even in the private sector here in Australia, it's hard to access. So for us, we wanted to think about how can we test what we can do to sort of break that cycle between substance use and PTSD. So this was done within our clinical program, thinking about what pilot sort of preliminary findings we could look at and potential impact. So what we did was kind of start to look at this space and think about what we were targeting in terms of people who are ready, willing, able to look at trauma-focused treatment. And really decades of research supports safety and efficacy of integrated trauma-based treatments. There's still a very strongly held myth within clinical settings across Australia, really, that people need to be abstinent first before they can undertake any form of trauma work. And we continue to get that sort of pushback from many services that our clients interface with. But decades of research really support that fact that you don't need to stop using in order to treat the trauma. There are a range of interventions that are really safe and effective and feasible to treat both problems at the same time. And I've listed a few of those there that are supported by a whole range of meta-analyses, but we chose to go with a treatment called concurrent treatment of PTSD and substance use using prolonged exposure. So prolonged exposure being the key ingredient there. And that intervention has been tested in a whole range of research, first in the US and then subsequently in Australia, proven to be really effective in clinical trials. But there was a translation and sort of implementation gap. So the research kind of a little bit halted in sort of 2012-ish here in Australia and hasn't kind of translated down to routine care clinical settings within drug and alcohol services or mental health services. So this is still not part of routine care or even accessible within the private sector for most Australians. So for us, we wanted to test, could we offer this within a routine clinical setting? And I put routine in inverted commas there because as you'll see when you walk through, we're a highly resourced center in terms of drug and alcohol treatment. We're not representative of all drug and alcohol treatment services in terms of our staffing profile and our skills base, or the capacity and the flexibility we have to be able to do studies like these. So we were really wanting to kind of pick up from this program, what could we learn if we wanted to implement this more broadly across drug and alcohol services? We also wanted to scale up our team who'd never done anything like this before, never worked in the prolonged exposure space before, really skilled in drug and alcohol treatment, but not in trauma treatment necessarily. So we wanted to kind of build up that capacity and confidence of the team and build in supervision to support that. So this was set up in collaboration with Professor Kath Mills at the Matilda Center and Professor Sudhi Back at the Medical University of South Carolina. Just about pre-COVID, and then we went full swing into COVID, did all our supervision online via Zoom, and did all of our treatment during the period of COVID as well. So our model, just to give you a bit of a snapshot, is targeted specifically at women who present with both trauma and substance use disorders. And in that implementation of taking it from a research trial to the clinic, there are a couple of extra steps that we added to the process that included secondary consultations. So everyone was referred to our service. Had a fairly extensive process of discussion with the referrers, with the treating teams that external to the space, because working in a trauma-focused space is not necessarily familiar to most of our referrers within the drug and alcohol treatment sector. So we had to figure out between the referrers and ourselves and the clients, is this intervention right for this person, for their symptom profiles? We also added an assessment step that was fairly formal that included some joint assessments with the psychiatrist and psychologist to kind of look at holistic kind of care profiles, what people actually needed in terms of care, making sure we're kind of crossing off other things that people need in terms of housing or family violence services or anything else that hadn't been addressed to that point. We also added a gold standard interview for PTSD, the CAPS-5. And broadly, that treatment approach takes about 12 plus sessions. Some of our clients took a lot longer than that, and we extended that over kind of 3 to 4 months when needed. So over this period of time, we had about 200 referrals. And you can see in that flowchart, this is really very similar to kind of implementation of this type of treatment approach internationally. That what we see is that many people get referred to programs like this, but getting that match between whether this type of treatment approach, which is fairly intensive, It's likened to sort of the boot camp model of trauma-focused treatments in that space, which has a lot of homework, has a lot of kind of commitments outside of session. So trying to get that match between the person who's referred to us, whether it's the right fit for them, and then also whether they're retained within treatment. Because exposure itself is a fairly intensive intervention. And classically within exposure interventions, what we tend to see is about 30% of the group drop out early on in the intervention, largely as a process of sort of fear and avoidance behaviors that come along with having PTSD. So, certainly our group saw a very similar kind of throughput, but we also really understood between that 200 to 71, I think a lot of work with referrers in terms of understanding what trauma-focused treatment looks like and helping the sector kind of come along with us on that process. So just giving you a bit of a snapshot of some of the preliminary data. The mean age in this group was fairly typical, I think, of most AOD services. 84% had had previous AOD treatment. 47% were unemployed and 19% were primary caregivers. And many people had experienced homelessness, but also if you look at the sort of family violence statistics, very high, especially when you think about the fact that if people were currently experiencing family violence, they weren't eligible for this program, we would be actually supporting them to find a safe space first. And so this is only the people who actually made it onto the program. So you can kind of see there that it's extremely high statistic. Of people who completed the program, that was 90% of people for whom the majority of people, their index trauma, their primary trauma they're working on was related to family violence. And if you think about severity of substance use within this group, we were seeing a fairly severe group from that space. And the primary drugs of concern, as you probably unsurprising, within drug and alcohol services would be alcohol followed by methamphetamine, with many people using a range of drugs together. In terms of those preliminary characteristics at baseline, this group reported fairly poor psychological health overall, high levels of dependence, but also high levels of depression, anxiety, and stress, as we'd expect, but also kind of flagging that these symptoms kind of cluster along with PTSD and with the substance use as well. So really aiming for the treatment intervention to target all of this together. And so for the people who did get retained in treatment and completed sessions, so we looked at both people who completed at least 4 sessions in the whole program. And we saw significant reductions in all of our substance use measures, as well as our depression, anxiety, stress, and CAPS-5 measures. So here you can kind of see that that was a significant reduction. We haven't done the full analysis of all of the group yet. In terms of implementation, just giving you a sense of, if anyone's watching online as well, the sense of if you wanted to try this at your own drug and alcohol service, this is the journey that our team went on. Thinking about training and the CAPS-5 training as well. So training in the measures, training in terms of supervision and clinician confidence, especially with the exposure work. This is a different area that, most of our clinicians aren't usually familiar or comfortable with. To start with. And so we really had probably at least kind of 6 to 12 months of people really kind of getting comfortable with this process. COVID-19 certainly had an impact. And I think even now we still have a small proportion of clients are continuing to do a little bit of telehealth, partly due to geographical kind of restrictions. So we actually are a statewide service and we have a number of clients who live kind of up to 2 hours away. And so they'd come in and do the assessments and things with us, but then do a lot of their other sessions remotely. We're also, learned a lot about developing that referral base, understanding both knowledge in terms of primary care and drug and alcohol services, knowledge around trauma, PTSD symptoms, and developing that as well. And I think at this point, 2 years down the track, we're still really kind of conscious that there's a lack of other accessible options for trauma-based treatment in the space. So having said that, what we'd really like to do is think about, for that other 70%, who may not be eligible for this type of treatment, this may not be a right fit for them, who may drop out. What else do we offer for the rest of the people who have really kind of disabling symptoms, but for whom exposure-based work is not the best fit? This is still the only trauma-focused integrated treatment that our service offers, and as far as we know, the only public service here in the state. And so really trying to understand how do we make this more accessible and how do we offer more options to people who want it? This is highly resource intensive and can't be necessarily translated everywhere. So thinking about how we implement that more broadly and what those challenges might be. And also thinking about those stepped care approaches that we could kind of consider in this space. So people who might require less intensive interventions, also interventions that might be less cognitively focused, because we know that this is based in CBT and is pretty cognitively heavy. And there are a whole range of kind of cognitive concerns for many people that we see. So thinking about sensory motor type interventions in this space or somatic interventions in this space. And as Vic has already mentioned, coming up soon, we've got a number of other interventions that we're going to be offering, including MDMA-assisted therapy, where we're using this type of treatment, COPE, the prolonged exposure model, as the backbone of the psychotherapy, and adding ecstasy or MDMA in 2 sessions to that. So we'll be recruiting for that trial in a couple of months. So that's me done. Thank you for listening, and a big shout out to the team and our collaborators, both here in Australia and internationally, have supported this to happen, and for Northwestern Melbourne Primary Health Network for their ongoing support of this work. Thank you. All right, so it's nearly made up to time now. So this is the time to get your votes in. I suspect we're going to announce the votes after morning tea, but please vote now. Yeah. Please vote for get your QR code, do the vote now. Going to break in a second. We'll just check if there are any questions from the group for any of our presenters from this morning. If you're not happy to share a question with the whole audience, you're really welcome to approach the researchers themselves directly. Any questions about any of the talks? Yeah, feel free to. Sure, do you want to come?
Still like quite new to the topic of like approach bias.
Yeah.
I was wondering what other control versions of the task were available, and why do you find the one that you use, like particularly using 50% of like alcohol related images compared to 50% of like neutral images?
You mean in the specifically in the control version? Yeah. So there's a few different control conditions that have been used in previous randomized controlled trials of approach bias modification. So sometimes people have just had treatment as usual. They don't get any kind of training. But the concern is there because the people getting approach bias modification are getting all this exposure to alcohol images, and they know they're participating in some kind of training task. You could have exposure effects that are unrelated to the approach avoidance aspect. You could also just have, placebo effects from just knowing you're doing something. And so therefore some studies also instead use something that tries to control for that, where people push and pull 50% of the alcohol pictures forward or backward. The idea, or in our version, they push them to the side rather than approaching or avoiding them. So the idea there is where you're pushing or pulling 50%, the idea there is that you're not systematically being trained to approach a majority or avoid a majority of the alcohol images. So it's supposedly it wouldn't be affecting your approach bias. However, some people have actually suggested that that kind of task could still affect your approach bias, because if you have a tendency to want to approach alcohol impulsively and you're being told to push away half of them, that could still reduce what you already have. So that's so people think the having no control condition like treatment as usual might be not well controlled enough, whereas having 50-50 might be a little bit conservative. We went with pushing and pulling to the left or right so that there wasn't any approach or avoidance, but just trying to control for exposure to the images and control for just to give people some kind of training tasks in the hope that they would kind of be blinded to whether or not they were allocated to a treatment or a placebo condition. Does that make sense? Yeah. All right.
Thank you.
Brilliant. Any other questions? We've got a question from Shanta. Yep.
Yes. Shanti, thank you for your presentation. I wanted to just pick up on some of the points you were making in your conclusion about the implementation part. And you pointed out that it was a resource-intensive therapy, 70% of the participants, being not suitable at the start. What can you do to be able to guide clinicians? Because I would imagine that as a part of, you talked about step care models, but I thought probably what's going to happen is a clinician is going to have some kind of algorithm to work out who is suitable and then which centre is going to be equipped to be able to implement a therapy like this. Is that a part of your research plan in terms of developing that kind of algorithm and validating it so that clinicians can be trained appropriately?
Yeah, that's a really good question, and just summarizing it for people online if they can't hear. So I think the question is largely around, in that implementation process, how we help clinicians kind of in terms of the decision making around referrals and thinking about algorithms in terms of guiding the right client fit to the right treatment. And that certainly has evolved as part of our thinking, particularly around sifting through that sort of secondary consultation process and understanding what referrers wanted and what clients wanted, and then what the symptom profile looked like, and then what the treatment match was. So it was definitely a process of evolution, because I think when I mentioned before, this is the first kind of go within a routine clinical setting. So trying to understand, what's coming into the front door. A lot of work has gone into that process of, we have lots of people kind of referred who may have experienced trauma, but might not necessarily be affected by that in their day-to-day. But that experience of trauma, when you have that discussion with your treatment provider, that often triggers off a conversation around, oh, perhaps I should refer for a trauma treatment, but it may not necessarily be what that person most needs at that point in time. So there's a whole range of different factors along that process. I think where we're at, what we'd really love to do is, first of all, I think, see what that suite of services look like at the bottom end of that algorithm. So I mentioned before, this is still the only one kind of chunked off at the end. There are a whole range of other interventions that don't directly specifically treat trauma, but are really effective on symptoms related to PTSD, sleep interventions, for instance, transdiagnostic interventions in terms of emotion regulation, distress. So those sort of interventions sit in that suite. But what we'd really love to see is some less intensive interventions also to add into that space, because currently there's very limited kind of options for clinicians to refer off to, if not to something like this. So we're thinking there's a range of interventions around written exposure, for instance, that are less intensive, that require less clinician time, less resource intensive, but also for clients, less burden. And doesn't require as much kind of narrative between the clinician and the client. So it can be less intensive in terms of vicarious traumatization as well for the clinician. So those sorts of interventions are things that we'd like to explore in a little bit more detail for an Australian audience. Again, something that's just started in the US. And I think over time, we'll be able to kind of build out what does that algorithm look like. But yeah, certainly something we're thinking about.
Thank you. And just one quick follow-up. I missed the demographics. Did you have any first responders in your participant group?
Interestingly, no. So this was all comers, women. So it's a women-specific program, but open to all comers, and largely perhaps as a result of the fact we're a drug and alcohol service, and we had a lot of drug and alcohol referrers, had hardly, I would say at the top of my head, 0 first responders in this population. The index traumas in this group were almost exclusively family violence or sexual assault. Yeah. Yeah. Cheers. Any other questions from the audience? So no burning questions. We might draw this session to a close, but feel free to approach all of the research team during the break. We're going to close now and come back at, I believe, 11:30. There are some tours as well as some refreshments out the front. And then when we start again at 11:30, our next session is going to be focusing on consumer perspectives, and will be chaired by Dr. Michael Savage. Cheers.